You are listening to Lifeboat for the Whitecoat podcast.
This is the Lifeboat for the Whitecoat podcast number 9. And today we welcome Dr. Tim Murray, who has been an exceptional leader in the state of Wisconsin for opening multiple practices in the independent DPC space. Welcome, Tim.
Thank you. Appreciate you having me.
Thanks, Amy. We're here with Amy and Heather and Chris today and the Lifeboat team and the Lifeboat podcast. So thank you for tuning in. This is going to be a really cool one. Real doctors, real stories. And unfortunately, a lot of those stories are more of the norm than the exception. So thanks, Tim, for joining us. Tim, I've known Tim. Tim actually and I work together, and I'm still the Wisconsin chapter leader for FMMA, but in what we call the Wisconsin movement, which is, and big thanks to Tim, really moving pretty fast and moving forward. And Tim and I have known each other for years. And I would call Tim a friend, and what he's doing, he's currently in Bulgaria. So how about that? And adopting a child. So talk about dedicated to helping others. So welcome, Tim. If we run out of time today, which we try to keep these a little bit shorter, we can always do a follow-up as well. So keep that in mind.
Sounds great.
I'm sure we'll have more to talk about than we have time. So we can start off. Would you like to maybe just give us some backstory? By the way, one more point of intro. Tim is the only doctor that I know of in the whole nation that has DPC and DSC at the same time, and it's just doing amazing things for others. So please, Tim, share us a bit of your story.
Appreciate it. Thank you for the intro. Yes, we started our company, Solstice Health, back in 2012. So we've been around for almost 13 years. The catalyst, I think, there were several catalysts, but one of the big catalysts was sitting in the operating room. I'm an anesthesiologist by trade, and sitting in the operating room and seeing the way that a lot of these things are billed out on a case-by-case basis, and also caring for people that need additional help in different ways, especially within the United States with what I consider the largest pandemic of our time, which is obesity. And so it was a combination of a wellness desire for the general population, but also to try and fix the way healthcare is delivered. I would often see, for example, a knee immobilizer brace after an ACL repair being billed out at $200, and then to come to find out the hospital loses $3 million in rural subsidies, and suddenly that same knee immobilizer brace is $800. So when you start to dig on those types of things and you realize that the charge master is a very real thing, and wanting to understand that better, it exposes you to a lot of different things that I think most physicians aren't even exposed to or really understand, mostly because the movement in Wisconsin and beyond has gone to an employment model within the hospital system. So that was some of the catalysts why we started. My background as an anesthesiologist by trade, I started out in general surgery, and realized very quickly that I ruined my life. And so I decided from a procedural standpoint, and in between that, I did some ER and urgent care. So I had some pretty significant exposure to a lot of different facets of healthcare. And that's sort of what allowed us to start the company the way that we did. So it's been a long journey, certainly for the past 13 years, but it's been a good one. There's been some immediate slow growth at the very onset because people don't know what direct primary care is. They don't know what direct surgical care is. Most people are only accustomed to having a plastic card, walking into a healthcare establishment, handing it to them, and really not knowing what's going to happen after that, not knowing what the cost is. The surgeons don't even know what the cost is when they're going to do an operation. So for all of those reasons is why we started Solstice Health, and we've continued to expand now to 5 clinic locations and 1 ambulatory surgery center, and hoping to open a couple more locations this year.
When did you start? Just curious. I know it's been roughly 3 years, maybe 4 years now for the surgical center. When did you start thinking about that, Tim? And was it a long time ago, or what kind of sparked the creation of that?
So for me, obviously being in the operating room, an ambulatory surgery center is sort of the holy grail for me. I knew very early on, within the first year that we started Solstice Health, I was down at the first FMMA conference and met Keith Smith, who is who I would call sort of the godfather of direct surgical care. And he's been doing it now for a very long time. And so we had a lot in common because he's an anesthesiologist, and was doing, sort of the same thing that I wanted to do. And so he became sort of a mentor and a role model. The business model was also a role model for our business. On the surgical side, obviously they don't have direct primary care, but that's really where I eat, sleep, and breathe, is in the operating room. That's where I spend a lot of my time. And it was interesting, as we were doing direct primary care early on, we would send patients down to Keith Smith. So I would call him up and say, hey, I have a hernia patient. He would then connect with the patient, put them in contact with the surgeon. Patients would fly down, pay $3,000 to $4,000 for a hernia repair, plus an overnight stay in a hotel and some plane fare, and they'd still be saving $20,000 or $30,000. So it became apparent in talking with him, that was really something that we could do in Wisconsin. It's not something that's easy to do. And so it took us a number of years it was really more financial constraint than anything, when you don't have any partners and you're sort of working and hustling to try and do the best you can for the community. And so once we finally got to that point that we could, we decided to take that leap, and it's been very good for us.
You are listening to Lifeboat for the White Coat podcast.
The story that you explained so far is great, but how did you, let's start truly from the beginning. How did you spin up your first location? I mean, did you fund it yourself? Did you get funding from somewhere else? What was the catalyst, and what were the pieces that you put together?
Yeah, so I was about 6 years into private practice. I left residency in 2007, 2008. And as I sat there, for the first 6 years of my career, it became apparent to me. I think one of the biggest passions I have is wellness. I think aside from the healthcare system being corrupt and bankrupt, the American food system is much the same. I think that's one of the main catalysts for much of our disease in this country. And it's honestly very difficult to care for morbidly obese patients in a way that they want to be cared and deserve to be cared for. Even things as simple as, when we have a patient come in, we have to make sure that the operating room table will hold 500 pounds plus. And so we're having to look at different manufacturers and different things, and that increases the cost of healthcare. So all of those things really came together in my mind as like, this is creating so many problems, and it's an easy fix. It's not hard, because obesity is not a disease, despite what the healthcare industry is going to tell you. It's an American food system problem, and the fact that we eat too much food. So that for me was one of the big catalysts. And so as I looked at that, and I was looking at what was going on in the operating room and seeing how they bill differently, I really started to realize, wow, this is a scam. Everything that we're doing here is just a big giant scam. Yes, we're giving good care to people, but the way that it's being billed out, and the way that doctors are being paid and nurses are being paid, and the way that they recruit people, it's a big giant scam. And so that for me really set me off, and I wanted to dig a lot further. So I thought, what can I do? Obviously, physicians who are employed are always non-competed, so it creates a huge barrier to be able to do anything from an independent standpoint. I happen to be an independent contractor with a large group in Milwaukee of anesthesiologists, and we were contracted through a hospital. And yes, we did have a non-compete in our contract, but it was a specialty specific non-compete. And so as I started to think, what can I do? How can I open up a clinic or a wellness clinic that we can start to care for people in an appropriate way, and really focus on weight reduction, and then get them to a place of wellness that they can start to enjoy sort of the true wellness space. And so I found a location that to me was built out appropriately. I think it actually was a previous either an orthodontic or dental location. So there was some individual rooms that I didn't really have to build much out, which was important, because obviously but you want to spend as little as possible when you're starting a new business. So I found a place that I didn't need to do much construction to, and leased it. And it was me and a nurse, and that's really how we started out. I found a nurse from locally that wanted to work and also be outside the system. And so we started the business together, and it was sort of like we walked in and opened the doors and looked around and said, okay, now what do we do? We didn't have any patients. We didn't have any marketing tactics or anything else like that. It was just us trying to figure out how we could help the general population with one of their bigger issues. And so that's how we started. And it was tough. It was a slow road. And actually what ended up happening in that particular setting is I opened up in April, I think it was, of 2012. I got a phone call in July of 2012. I was on a 2-week vacation from the hospital, and it was my group president. And my group president said, Tim, the hospital called and they think you're competing with them. And I said, well, obviously that's not true. I'm not doing anesthesia in my little clinic in Oconomowoc. And so we went back and forth on that. I finally met with them. Make a long story short, I met with the hospital president, and I said, listen, I'm not competing with you and I'm not violating my non-compete. And he said, well, I understand that, but it's the spirit of the contract. And I said, what does that even mean? The spirit of the contract is the contract. And so shortly after that, the group president called me back and they said, listen, this hospital, they don't want you to come back. So I went from, 100 miles an hour and I hit a brick wall, 2 weeks later, and I had no job, I had no money, and I had a clinic that was underwater. Because that was one of the offerings they made, is like, if you close your clinic, then you can stay at the hospital. I said, well, obviously I'm not going to do that. I've spent too much time putting this together. And so we just, we hustled out. That's when I started doing independent contract work in the operating room. So I was working 2 full-time jobs at the time, running back and forth between those jobs. And it's just been a grind and a hustle, a lot of blood, sweat, and tears ever since that time. So it's been a long road, but a good one, I think.
Thank you for that. I mean, just thank you for your courage and your persistence. I mean, SCO, Steve and Keith have stories like that, where even big insurance tried to put them under, right? I mean, they don't like that competition. Yeah. They love the game just like it is. And yeah, just thanks for pushing through, because it's so good now what you've got.
Yeah, it's been a blessing to watch God sort of position everything as we were moving along and open up a second location and then moving on from there. So it's not by design, but by his design. And so it's been really good.
Amen.
When you were just opening your doors and up against that brick wall, that's where really the rubber hits the road. And oftentimes when you're owning a practice or a business, what did you do to get your first patients, and then grow and scale so that you felt comfortable to launch into a second location, and then third, fourth, and fifth?
Sure. Yeah, we obviously, when we hit that brick wall, it was more of like pouring my own finances into it at the time. And to be able to gain the first couple of patients, I think because we had known so many people locally, and they knew that we did open this clinic, at least through friends, family, etc. We had them come in and we offered discounts and things like that to be able to get them. One of the biggest things, I think, was our weight loss program. We started a weight loss program. It's not your traditional weight loss program like a Jenny Craig Weight Watcher Nutrisystem, because we really wanted to find something that was studied, that was real, that was actually fixing the problem, which is pancreatic dysfunction, because of the American food system. Currently, we're consuming about 150 to 200 pounds of sugar per year. Early 1900s, it was around 5 pounds of sugar per year. So the problem is obvious. It's not rocket science. And so when you bring someone in like that turns around and loses 50, 60, 70 pounds, and then goes out into the community, they're like, holy cow, what happened to you? Are you sick? First thing they say is, do you have cancer? Are you sick? And it's like, no, I'm actually healthy because I'm down to a reasonable weight. And so then that word of mouth is really what triggered a lot of different people coming in specifically for our weight loss program. And as we did that, most of those people were on diabetes, high blood pressure, high cholesterol drugs. Well, when you change your insulin levels and you decrease that and you stop the pancreatic dysfunction that people have on a daily basis, the first thing to go is your high cholesterol medication. Second thing to go is your diabetic medication, and then plus minus high blood pressure medication, depending on what the base of the disease is. And I mean, it happens in short order. Men are losing about 4 to 8 pounds a week, women 2 to 4 pounds a week. It is safe. It's very real. Like I said, it's studied at two different universities at this point. Some of the hospital systems up north in Wisconsin actually offer this plan, which is sort of interesting. And so I think really that word of mouth, by seeing a stark contrast of a sick patient versus a healthy patient, really started, put the ball in motion for us. And then as people come in and say, well, can you take care of these medications that we have? And my answer was, well, sure, I can do that. I'm a doctor. I know all about these things. I mean, anesthesiologists probably have the most experience in overall physiology than any other physician. And so that was something we said, and that's sort of what spurned on direct primary care in the state of Wisconsin, being the first successful clinic to do that, and continue that and grow that panel. Direct primary care itself was slow growing, obviously. People didn't know what it was. It was very hard to sell because they didn't believe it. But once you got, an individual on, again, we really grew very quietly. And I think for the most part, we're still growing pretty quietly. We're a little more vocal now, and we have a marketing team that's helping us out now. But probably for the first 8 years or more, it was all organic growth. And it was more people seeing other people that they knew actually in a setting of health as opposed to a setting of sickness. And that just triggered more and more word of mouth converts. So it's been slow growth, word of mouth growth. Probably the last, I would say 5 years, 6 years, it's been a little bit more dramatic, the growth that we've had, because once you gain a family that talks to another family, that obviously there's multiples there. And when you gain a business that's, 10 people or 15 people or 30 people, all of a sudden people start to talk and wonder, how can my business do this? How can my business save money? And so the leadership of each business then can talk to other leadership that they know. So it's sort of a snowball effect. And then when you add marketing to that, it's just icing on the cake.
You are listening to Lifeboat for the White Coat podcast.
Hey, Tim, I got a question for you. You mentioned, this is Chris Abick here, and you mentioned when you first started, it was you and a long time kind of front office person. Can you talk about the cultural differences that you see with your employees, with your teams across all the different sites, and how that differs from what most doctors and nurses are used to in a traditional hospital system?
Sure. Yeah, I mean, we get a lot of people ever since the minute I opened my doors. Everybody said, I want to come work for you, because they're tired of working in the healthcare system. They're tired of the bureaucracy. They're tired of being treated like a cog in a wheel. I can tell you very personally, in the operating room, when you work at a health system, it's unbelievable to watch the amount of turnover. Not only it's not so much doctors, because there's a limited amount of doctors, but there's unlimited amount of nurses for the most part. And so the turnover was just unbelievable. And the way that they have these places set up is, a new nurse will come in, and again, this is operating room specific. It's the same on the floors, but operating room specific, they will come in and they have to do training for 6 months, for example. And they go from each operating room to learn each different specialty. They give them signing bonuses, what have you. And then once they reach 6 months, they're sort of free to take call and do all these things. By the time they get to 6 months, they're like, I don't want to be here. I don't want to be in there. This is terrible. And so that's a continuous cycle of pain in the operating room. And what ends up happening is, because we always, like the doctors, the nurses, the techs, all these people, the staff inside the operating room, like, we eat, sleep, and breathe surgery. So we know what we have to do for these patients. And ultimately what we do is we keep churning out the same amount of cases with less staff. And what do the suits see when they're sitting in their ivory tower? They say, wow, we're churning out the same amount of cases, probably even more, because these people are taking extra call. They're making extra money when they take extra call. Maybe we don't need to hire people that quickly. And so we're doing more work with less people. And then there's this wonder of like, oh my gosh, burnout. Why is, well, the burnout to us is obvious, right? I mean, because we're doing more work with less people. And there's an expectation there to do it, but there's also there an inherent desire to do that, because that's what we got into this business for, is to help people. And so if we have to stay extra hours and do extra work, that's what we do. But they're, getting an umbrella with the hospital logo on it on Doctor's Day is totally worthless. And so these people don't have a freaking clue what they're doing when it comes to like treating their employees well. On the other hand, I came from that. And so if you talk to any of my employees, they love the culture. You know, when they come in, they usually do a shadow day when we're recruiting and hiring, and they just can't believe it. And they love the culture, and they want to work with us because they know that they're going to be treated with respect, because everybody has a job. They have a certain amount of autonomy that I like to give them, because if they know their job and they know their craft, they should be able to do it without me micromanaging it. And so it's just a completely different atmosphere, and why I think more and more people are wanting to be outside of the system to work with us.
Yeah, just a quick follow-up on that one, because I think that's a great point you just made about the micromanagement and the control aspect of that. And we see that a lot in medicine, that, you know, if somebody's not chained to their desk, then are they actually working? Why am I paying this type of person? It's just that mentality that is pervasive in residency. And it is drilled into a lot of physicians who then want to become business owners and then just completely flame out, you know, from their employee standpoint. Just a quick follow-up. So, you know, you talked a lot about your staffing and you know, the experience from the physician standpoint. How does that patient experience compare to what a typical patient, when they walk into what a hospital OR is going to look like? Not knowing a surgeon, maybe meeting the surgeon one time before the operation, no follow-ups. How does that compare to the patient experience when somebody walks into one of your clinics? Because I think that's a huge point to drive home, is just that it's not volume-based anymore, and very relationship-based. So curious to see how it works.
It is. I mean, I think the first thing you see when you walk in is that a different brick and mortar mentality. You know, there's no glass windows in front of our reception desk. There's no closed doors to be able to get back to the, you know, the point of no return into the clinical space. It's open. It's very open. It's a nice feel. It's, you know, our sort of logo colors are orange, which we think is bright, and it feels great. But the way that we schedule, it's interesting that you asked this question, because we have had more problems specifically with corporate people coming in, corporate leadership coming in, walking in for a tour of our location. And the first thing they say when they walk in the doors is like, well, you know, or we hear afterwards, the dialogue afterwards is like, yeah, I don't know if this is, I think they're too small. There's nobody in the waiting rooms. You know, it doesn't look like they're busy enough to house our location or house our employees. And I tell people all the time, like, the worst real estate you can buy is a waiting room. Like, there's no money being made in a waiting room. That's just generally across all real estate. But our waiting rooms are very small, and they're small for a very specific reason. I don't want people waiting there. We schedule our appointments so that people can walk in the door and go right to the exam room, see their provider, be done, walk out. If they need to go into, you know, a different area to get an IV or something like that, it's all very open for them and accessible. And so it's very intentional. The average FaceTime, obviously, with a physician in this country nowadays is about 7 minutes. And I joke saying, you know, most people can't make it out of the bathroom in 7 minutes. So how in the world can you do healthcare? And it's easy because we have polypharmacy, right? Like, you just prescribe something else and prescribe something else, and the patients don't know any better. They're like, oh, well, I got something now for this symptom that I talked about. Well, the symptom happens to be from another medication that you don't need to be taking because someone prescribed that before for you. So people need to be able to sit down and take time and talk to these patients. So our establishing care visits, for example, in the primary care space, are about an hour. If they need to be longer, they can be. If they need to be shorter because the patient doesn't want to take that much time, that's okay too. It's really the patient dictates how that's going to be. And so that way you get to know the people. You can get everything on the record, so that next visit for 15 minutes or 30 minutes can be a dialed in visit if they want it. They can have another longer visit if they want, but they have same day, next day visits guaranteed through the direct primary care aspect. Which is a huge help, because there's never a need for urgent cares. Urgent cares are the biggest waste of healthcare dollars, right next to ERs, because they don't need to exist, right? They only exist because the ER docs didn't have time to see the headaches, and the primary care docs didn't have time to see them either. So that's why urgent cares were born.
You are listening to Lifeboat for the White Coat podcast.
On the surgical side, it's sort of an interesting, not only like Surgery Center of Oklahoma, but also our surgery center. If you want to know who the best surgeons are, ask your anesthesiologist. And that's me. And so that's what I've been doing, is going around for the last, you know, I don't know how, it's been almost 2 decades now, of, operating room to operating room, really getting to know different surgeons in the area. So I've been able to go around and hand pick who I would want operating on my family. And we have operated on my family there. My son had his he had his ACL done there and also had his elbow done. And then my mother-in-law. So like, these are people that I would want operating on me because I know them. I know their skill. I know their bedside manner. I want the best for my patients. And so that's also another thing is internally as we are able to, because I don't have any restrictions, I'm not beholden to anyone, is we're able to buy the best equipment for our patients. I don't need a suit or an MBA coming in to tell me what tools I need to put someone to sleep. Like, you listen to me when I'm putting someone to sleep to take their life in my hands day in and day out. If you want to go to anesthesia school for a little while and then come out and try and tell me what to do, great. But otherwise, their best bet is to keep their mouths shut and continue to figure out how to do their job on the ivory tower side and let me do my business. But like, for example, an LMA, it's a little laryngeal mask airway that we put in the back of the mouth. Any hospital I go to, they buy these little crappy $2 LMAs, and I have to jerry rig a tongue blade with, 3 4x4s wrapped around it with tape to put it in the patient's mouth so they're not able to bite down. It creates a bite block. At my operating room, I buy a $6 or $7 LMA called an iGel because I love it because it has a bite block right in the middle. I can put it in. It's nice and smooth and easy, and my patients are safe without having to jerry rig anything. And so it's just, everything is different in that aspect, not only from the minute you walk into one of our DPC offices, but also from the time that you see our surgeons, knowing that you're getting the best care. It's the same surgeons, anesthesiologists that you would get in a local hospital because they are independent and they can choose what they want to do. And they love the model that we have, and they love working with us because they know that they're doing great things for healthcare. Sorry, that was a long answer.
Great stuff, Tim. We know you're out of country, so we want to respect that. I mean, I think there's so much more to talk about here, right? I mean, just thank you for that. And you and I have had discussions about the quality. We see the quality pop out a lot, that not only is it a quarter or less of the price, which is kind of almost hard to believe, right? Is it too good to be true kind of thing? You've talked about some of the surgeons, and we'll be careful, right? But right, the alternative to the hand-picked surgeon is what you would call the butcher. I'll never forget that. Those random pick, and we probably don't have time to get into that now, but I think we should cover that next time. I'm going to throw that out there as a teaser about, and the thing you talked about, the insert, the LMA, these are quality things too. These are patient
100%.
And so we're talking about this lean type mindset where you get a lot more and you pay a lot less, and it's because it's efficient and it works like it's supposed to. I'm going to throw you a kind of my home run question for this first round.
Okay.
But we'd love to have you back. But the question I like to ask, right? We know there are many physicians probably listening to this, listening to MDs like you, and very frustrated, feeling like they don't have a new lily pad to jump to. What do I do? I'm trapped here. We hear all the golden handcuffs gets brought up all the time. What would you tell those physicians that are listening to this about their options and what they can do if they're frustrated?
I think first and foremost, and I sort of I beat this to death in the operating room because I see so many people feeling like they're trapped, not only nurses, but the surgeons themselves, if they're employed. Primary care on the floor in the hospital is a loss leader, right? It doesn't make any money. All the money for a hospital is made in the operating room, almost 100% of it. Now they've got infusions and all this other goofy stuff that they're killing people on. But the operating room is where the money is made. And I don't know how I can't get it through people's heads to tell them, if you take a surgeon, an anesthesiologist, a nurse, a tech, a scrub tech, that's like the most powerful people in the hospital. And like, we have a craft, we went to school for it, we learned for it, we studied for it, and they're billing everything off of our backs. And all you got to do is walk away. The minute that group of people walks away, a hospital will literally implode. The problem is no one has the courage to do it for various different reasons. Obviously, there's financial reasons, there's family reasons. The physicians in particular are non-competed, and so sometimes they have to move out of state or drive like I used to, an hour and a half away and then an hour and a half home every day just to avoid non-competes. So I think there's that as a barrier. But I always tell people too, when it comes to direct primary care space or direct care space, and it may have been longer ago to say this, but I would always tell people, if you build it, they will not come. I promise you they won't come. I did it for years. I sat there for years waiting for people to come and they didn't come. Now it's a little bit different. It's more of a buzzword. There's more clinics around the state, obviously, and across the country. I think there's 1,500 different clinics. And so I think that this is a very strange space in that normally when you start a business, you think it's your own proprietary thing and you don't want to share because you don't want competition. In this space, competition isn't such a bad thing. And so it's been very strange. The day I met Keith Smith, however, 13 years ago, he told me how. The minute I went to the first DPC summit back in, I think it was around 2013, 2012, some of the leaders in there, the original DPC leaders, they told me how. Like people are willing to share. I think there's probably less of that going on now because it's now becoming more of a thing. But I would encourage them to ask those questions like, hey, can we get together? Can we figure out how this is done? And you're going to have to take a risk, right? I mean, if you have money, you can always, raise capital. People, I don't know how to raise capital. I just go out and make money. But there's ways to raise capital. Obviously you can take loans out, home equity lines of credits. You're not going to get into any space. If you want to go start a construction company, you're taking out a home equity line of credit, whether you like it or not. You're going to have to take a risk. The risk is worth it because you're in charge of your own schedule. And most importantly, you're in charge of the care that you give your patients. You're in charge of the way that, or the things that you purchase for your patients. You don't have to necessarily follow the quote unquote rules that the 21-year-old sitting in a cubicle is telling you how to do. If you know you've got a soft tissue injury, you can go straight to an MRI, right? You don't need to get the stupid x-ray, which there's no broken bones, and they don't need physical therapy right off the bat. They need an MRI and they need a surgeon. So you can bypass a lot of the red tape and bureaucracy and do what you were trained to do, right? Like to diagnose, to sit and talk to a patient, history and physical exam, diagnose them, and then find a diagnostic tool if you need it to help them and get it done in short order. People don't need to wait 6 months for an MRI. You need an MRI tomorrow, and so you can do that in this space and really do what you truly love to do. So it's well worth any risk that you take, but you have to go into this knowing that there's some risk. There's going to be some pain along the way. You may have to take a little bit of a pay cut at the beginning, to grow things until you get your panel full, and then all of a sudden things are going to be great. There's a lot of different nuance to starting any type of business, specifically in the DPC and direct surgical space. But it's worth it. Like we started out in our direct surgical space and we had a lot of equipment that we bought, but I can tell you today, we got a whole lot more. Nothing that I would have bought up front, but it slowly accumulates as you do different cases. So you can stage that growth. You don't have to do everything right away. You don't have to come into this space spending $1 million. You can get into the space and like we did, find a space for lease that's already got a couple of rooms built out. That's all you need is an exam room. And then you need a stethoscope, and then you need a blood pressure cuff and some medications and things like that. All these different things you can buy. And those things are they're not hard to do. So, leverage the knowledge that's out there, be willing to take a risk. And then you'll have a mini nirvana in terms of like taking care of patients.
I used to say as a 25-year HR leader, that we encounter a problem and we'd say, is it worth going after it? Is it worth the sacrifice? Is it worth the pain? Is it worth the cost? And I'd say, let's see, how many years of career do we have left? Right?
Yeah.
Oh, like 35. Maybe we should go after it this year. I think it's worth it. Right.
Exactly.
And I think that probably a lot of physicians that have maybe a ton of decades left of career. Is it worth just putting your head down and taking that, suffering in a very rough way, or actually taking a chance and trying to make it better? So Tim, let's close there. Thank you for taking the call today. Thank you for taking the time out of country when you're out of country. Certainly a lot more to talk about. How can people reach you if they want to find Solstice or you? What are the best ways?
Obviously they can reach out to any of our clinics. Our staff know how to get a hold of me, but my I don't know if you want my email. It's TMURRAY at solsticewi.com. shoot me an email, and then we can connect on a deeper level via, I text a lot. I'm like an expert texter. So reach out. I'd love to help. And if I can be obviously of any help to you guys as well, we'll talk about more. I've always got much to say.
Thank you so much, Tim. And for those of you that are listening, if you don't want to jump on your own boat right off the bat, there's a reason why that we created whitecoatlifeboat.com. It is independent job positions, both support and doctor positions around the country. It is growing. People are adding new positions every week. So make sure you check that out. And if we can help, we can help. And Tim, you have I love how much the stories that you shared and how deep you went with it. And other doctors that we interviewed said the same thing. Just reach out to me. I will help you in any way I can, jumpstart your career. So thank you so much, and appreciate everybody for showing up today.
Yeah. Thank you guys for all you're doing. I appreciate the podcast and the help that you're putting out there online.
This concludes this episode of Lifeboat for the White Coat podcast. Please make sure you visit whitecoatlifeboat.com.